All right, good morning, everyone. Welcome to Pediatric Grand Rounds. Today, our speaker will be Dr. Amy Kryder from our very own Department of Pediatrics, who will educate us on the silent and deadly pandemic that has gripped our nation along with the COVID pandemic, the skyrocketing of mental health issues in the pediatric population. Dr. Kryder is a graduate of the University of Maryland in nursing. She worked in the pediatric ER and PICU for many years prior to completing her medical school and pediatric residency training at University of Maryland. She joined the Carilion family 14 years ago and has been involved in different roles, including pediatric clerkship director, hospitalist, primary care specialist, the director of school nursing program, and former section head of community medicine. Her primary career focus at this time is primary care pediatrics in Botetourt County and promoting the care of children's mental health on a statewide level through her leadership position with the Virginia Mental Health Access Program. She's almost an empty nester of 2 children, but will never be alone or apart from her one true love, her horse babies. Please join me in welcoming Dr. Amy Kryder.
Thank you, Vidya. So, good morning, everyone. This talk is entitled Children's Mental Health, Our New Mandate. It's the first in a periodic series. I don't know how long it's going to be. I think I have 3 grand round dates scheduled this year. So I wanted to start out with a little bit of background about me. Dr. Parmeshwar gave me a great introduction, but really I want to tell you a little bit more about me personally. First, while I eventually won the primary care award, I probably was most likely to be a PICU attending or most likely to be an ER attending. Would have been my award as a second-year resident. In those days, you could make money moonlighting, believe it or not, as a resident. So I worked nights. I would sub as an NP in the NICU. I would also occasionally, I can't believe that they let me do this, would sub as a pretend fellow in our PICU. So when I graduated from residency, I was just primed to be in the hospital. I could titrate vasopressors. I could calculate your cerebral perfusion pressure from your intracranial pressure monitor. I could manage vents, but I couldn't manage ADHD. Had no idea. I had had a month of behavioral health, which gave me 1 day of shadowing someone who did med management for ADHD. I could put in an art line, but I had no experience diagnosing, treating anxiety and depression. I can't think of a single patient that I saw in my residency that I treated for those conditions, either alone or supervised. Residents today are actually more fortunate than they realize in their preparation for primary care. They get some training in these areas, but I'll be honest, you don't get to see outcomes over time. And that is really powerful for both your motivation and your education and knowledge and how to do this work. So when I started practicing primary care, I had been in the hospital for a year at that point as a hospitalist. And I remember so often discharging people with a plan of follow-up at Blue Ridge Behavioral. And I thought, what is this magic place that people can follow up and actually get care during when they leave the hospital? That wasn't available in Baltimore, where I came from. And then I got to outpatient, and the reality smacked me in the face. We made that plan, but they couldn't follow up there. They couldn't get it in a timely manner. If they had the wrong insurance, they didn't take them. Most of my patients in my practice have private insurance. Blue Ridge Behavioral doesn't cover you if you have private insurance, only if you have publicly funded. So where did those kids land? They landed right in the lap of the primary care providers. And what happened? Well, we weren't educated, we weren't trained, we did our best. Luckily, I had some mentors, John Moore and Colleen Kraft at the time. Both had some comfort, or a fair amount for Colleen, in the care of patients with mental health problems. So I learned on the ground. But for other families, it caused a lot of distress. Sometimes I didn't get it right. And so I had a choice. I had to either learn what I was doing or watch them flounder. And if you watch your patients flounder as a pediatrician, that causes a lot of emotional distress. It's very difficult to look at someone and say, I don't know how to help you. So what is this talk? Why is it a part of a planned periodic series? Well, I can't do it all. There's no way I can talk about all of pediatric mental health in an hour. Just not possible. So I have an open-ended series. Thank you very much, folks, to our CME committee. And with that, I have several topics, probably about 4, that I have in my mind to talk about. So in this series, I intend to give you some tools. I intend to give you some assessment methods and some treatment tools and resources. Can't cover it all, and I don't think the subspecialists and the surgeons probably want me to cover it all. But when it comes down to it, if you're, as a pediatrician in primary care, I have to understand what's happening in the hospital. As a pediatrician in primary care, I have to understand my patient's cardiac physiology. I have to understand what's happening in the neurology office. And I'm going to advocate that the other specialties need to have some understanding of what's going on with a child's mental health treatment and a family's mental health treatment in order to best serve that kid and to maximize outcomes. We just can't put our patients in boxes of disease processes. It's not fair to them, and the outcomes will not be the best. So as I talk today, I'm going to challenge you guys to do the following. I want you to think about our current system at Carilion Children's. How can we make it better? How can we collaborate more? And remember that all of our patients and families have challenges. You can't treat the kid outside of their social situation. You have to understand that social situation, because meds alone don't do this. So at the end of today, I'm going to ask you to share ideas. This is not just, I don't want just a Q&A unless you guys want that. But we'll have a chance to talk about what could we do better. And even if it's just through the chat, I'd like to talk about what can we do better. So as I said, I might ask you to put things in the chat box, find your chat. And with that, I'd like to go ahead and get started. So I'm going to share my screen. And here we go, folks. I'm going to pull my chat up really quickly. I didn't realize it would turn off, so just forgive me. There we go. Now I can see you guys. So that's great. All right. So I already told you what our title was. And with that, here are my disclosures. I don't really think that these are conflicts of interest, but just out of full disclosure, I am, as Dr. Parmeshwar said, I am the Virginia Mental Health Access Program lead for a program of education called REACH. And that is a national organization started by some real child and adolescent psychiatry powerhouses, including like the guy who wrote the Vanderbilt folks, some of the NIH researchers in the Sentinel trials that happened in the late 90s and early 2000s that were true publicly funded mental health trials, and how do we best treat ADHD, depression, and anxiety. There's still the highest quality research that's out there. And I teach for that organization nationally as well. So I've been able to teach with the guy who wrote the Vanderbilt, which is actually kind of cool. So with that, I have stolen some slides and I am going to give full credit for that. One, I've stolen some VMAP slides. Sandy Chung, who is our incoming AAP president next year, graciously gave them to me, and the Reach Institute has allowed me to use some of their information as well. So what are today's objectives? Well, we're going to define the landscape. Where's children's healthcare nationally? What is all about this mental health care crisis that we have seen in the news? I'm going to talk about VMAP. What is it? And mostly we're doing a lot of good things locally. So I want to explore and talk about what are we doing successfully at Carilion Children's, because I don't want to forget that. And then finally, as an introduction to this series, we're going to explore a screening tool called the PSC, or the Pediatric Symptom Checklist, and talk about why we may want to consider going to that as a children's system. I promised you future sessions. I've got some future sessions based on depression and anxiety with some tentative goals. And we'll talk about the scary things like the box warning for antidepressants and what does that mean? What is that risk of increased suicidality and suicidal thoughts if you start to treat someone with an antidepressant? Talk about long-term outcomes for these kids, and give you some more tools for your use. Got a session planned on ADHD. And why is it that we treat it? You know, it's not just a school-based problem. There are lots of long-term outcomes and data around those. A lot of those studies come out of Canada. And there's a really compelling case to treat these kids because we can make a real difference in their life trajectory, not just how well they learn in school. We'll talk about suicide if you want, and self-harm. What's the difference? What's common? What risk factors are there for someone actually attempting and completing? Also, what are protective factors and how can we mitigate that risk? Because we don't want our kids to attempt suicide. So there's a big problem nationally. Even prior to COVID, the data I'm about to present to you is prior to the COVID pandemic. The problems are all too common. Our children and our teenagers are in distress. If you look at the natural history of mental health problems in children, 20% of them have symptoms in elementary school. Maybe they don't meet diagnostic criteria, but there are symptoms there. Almost half of them, according to the WHO, will present by high school, 14. That is a freshman in high school. I will tell you, I screen for so many things that are so low prevalence. I have had 0 elevated leads in my practice in Botetourt County in the last 13 years. But I do a lead on every 1-year-old. And if they've got medical assistance, I do it on every 2-year-old. Why am I doing this? I screen them for hypertension. I screen them for obesity. That's a high prevalence. But I am screening for conditions that are rare and uncommon. We are not routinely screening for common conditions of mental health problems that absolutely we know adversely affects the health of our patients. If we did so and we intervened when they had symptoms and not disease, well, maybe we could affect the trajectory of a life. Wouldn't that be powerful? And isn't that why we do primary care or take care of children in other areas? So, unfortunately, Virginia is not a magic place that is exceptional We may want to believe we are, but we're not. This problem exists in Virginia as well. So according to the VDH, our kids are feeling sad and helpless. These are studies that are surveys of children. They are using self-harm as a coping mechanism. Some of them are trying to kill themselves or making plans to do so. I had a kid yesterday in front of me, a boy who's 12 years old. He is a really smart kid. I have taken care of him since he was an infant. He is so articulate. He was cutting. His mom had found it. And when I talked to him about it, he said it relieves my stress. That was his reason. It's a coping mechanism. So national statistics bear this out. Suicide is the second leading cause of death of children ages 10 to 24. And according to the Institute of Mental Health, a Virginia youth survey shows that middle and high school students, a quarter of females and probably about 30% of males have seriously contemplated suicide in the last 12 months, pre-COVID. This says 2021, that's the publication date. That is not the study date. CDC data will show you that between the ages of 10 to 34, suicide continues to be the second leading cause of death. After that, the rate of suicide does not decrease, but it drops in the leading cause of death because cancer and heart disease simply exceed it in the rate. And then let's add a pandemic to that problem. The Virginia AAP and the Department of Mental Health statewide conducted a survey in August 2021. So that's not that long ago. That was 5 months, 6 months. And they asked primary care providers, what are you seeing? 90% reported an increased rate of mental health problems. Look at the bar graph. A 95% said they were seeing more depression and anxiety. Look at suicide in white. 54% were seeing more suicidality. And most distressing is that 62% said they are not prepared to currently meet the need. That may be education, that may be capacity. This question did not differentiate that. But my gut is that it's both. I work with a child and adolescent psychiatrist named Bella Sood, and she is out of VCU. Bella was recently telling me that the VMAP consult line, which I will tell you about in a few minutes, where anyone providing care for kids in Virginia in a primary care setting can call and get a child and adolescent psychiatrist. It's like a curbside consult. And they are finding she runs that access line. The CAPs are finding, CAPs are child and adolescent psychiatrists, are finding that they are giving support, almost mental health support, to the pediatricians and nurse practitioners and PAs and family medicine docs who are doing this work. This is creating a lot of moral distress in providers and probably contributing to our burnout. What are the drivers of this increased mental health crisis with COVID? This isn't surprising. It's loneliness. In fact, that's what my patient who was cutting told me. He's articulate. He said this started when school ended. I said, what was bad about school ending? I didn't have anybody around. And that's when he attributes his mental health problems for starting. He's had 2 ER visits in the last 3 months around suicidality. So to add insult to injury, what does our workforce in Virginia look like? Well, there are only 13 child and adolescent psychiatrists per 100,000 kids in Virginia below the age of 18. I did some math. That means that if every child were to visit a child and adolescent psychiatrist, and our child and adolescent psychiatrists worked 52 weeks a year, 40 hours a week, and did not take a single day of vacation, each kid could see them a half hour a year. With the prevalence of mental health problems, that math that I just did was not a stretch. That is why we can't get our kids into them. We can keep adding them, and luckily we have as a system, but we don't have enough access. So I'm going to talk about what it is we need to do to educate our pediatricians and our pediatric providers so we're just not stuck holding the bag without tools. 64% of Virginia localities are shortage areas. That's mostly around licensed mental health providers, 64%. And as I mentioned, 65% of pediatricians say they just don't have the knowledge about behavioral health skills. How do we compare with other states in Virginia? Well, we're at the bottom. We are 41st nationally for access to care among psychiatrists, psychologists, mental health providers. If we look at child and adolescent psychiatrists alone, only 2 counties in this state have sufficient numbers. These counties hold 24,000, 23,000 children of the 1.8 million in Virginia. Here's the map of Virginia. So this is the first time, get your chatting fingers out. Green, Albemarle County, and I had to look up this one, it's Rappahannock, have nearly adequate, nearly sufficient child and adolescent psychiatrists to meet the population size and the demand. Yellow is, I think, a high shortage. Red is a severe shortage. So what is gray? Somebody want to put in the chat what gray is? Hospitalist team won. They got it in the fastest. No, Dr. Ackerman, it's not no data. No, Dr. Temez, well, it is kind of dismal. It's none. So we are in a high shortage and severe shortage area right here of Carilion Children's. We are lucky. What if we were in Southside or far Southwest or out here on this little peninsula across the bay? How do you get access for your kids? So we need a unicorn. This guy's named Maverick. I promise you, he is my only horse picture today that you have to look at. But here's our resident unicorn. And oh, by the way, I shaved a unicorn cutie mark on his butt this fall because that is how awesome he is. VMAP is trying to be that unicorn. How are we doing it? We're doing it through education of primary care, a consult line, care navigation services, and soon to come, we hope, our telehealth to help in that consult process. But most of all, why are we doing this work? What is our goal? Our goal is to support the care of these children in their medical home where they trust. Why? Well, one, we're probably going to have better outcomes because they trust me and they know me over the course of years. But also we need to free up the child and adolescent psychiatrists. I need them to see my child who is hallucinating or my child who has bipolar disorder. That stuff is rare. I don't have any business treating that. So if I don't keep these kids and we don't keep these kids and support them, we are not going to be able to have adequate access ever in child and adolescent psychiatry. VMAP is broken up into regions. Just so everybody knows administratively, most of us are in the Western region. There are regional hubs within VMAP where there's a child and adolescent psychiatrist and a licensed mental health professional and care navigators. Unfortunately, we're not a hub. I find that sad. UVA is a hub and Centra is a hub. So we're lucky that we have them. And care navigation for those in primary care has been rolled out in the central area. I haven't used it yet, but I bet it's probably better than nothing, and I have to remember that it's available. And they can help access counselors, support services for our patients. So what's the process? Well, most of us start here, where we have heard about this thing called the VMAP consult line. And we get a complicated kid in front of us. We call the consult line and we ask for real-time advice. They get back to you within an hour generally, or you can schedule a call over your lunchtime. And if all of that is done on the date of service, folks, that's billable time now with the new coding rules. The call center will do a brief intake and set you up with either a psychiatrist or care navigator or both, whichever you think you need. And then hopefully in the future, we'll have that telehealth if the psychiatrist feels like, wow, I really need to talk to this patient and get some independent history. But back here, before that consult is supposed to happen, the goal of VMAP, that I am involved with, the arm of VMAP, is mental health education for primary care. What is that education? Well, we have 3 arms. One in green, I am happy to tell you we did before the pandemic. We did it before VMAP even got here. Scott Keel, who has gone on to do his residency in preventative health and is now a chief resident in his new program, helped me and Amy Kegels and some others do a hard lift of getting the SEEK program from University of Maryland instituted in our primary care offices. For those of you who don't know what SEEK is and don't remember the grand rounds from way before COVID, that is a screening program for mental health, social determinants of health, and including food insecurity, domestic violence, caregiver depression, alcoholism, etc. And that's actually what got us our outpatient social work department. We have a lot of our consults generated through them. So yay, Carilion Children's. VMAP also has Project Echo. Project Echo costs about $50. It is an 11-month monthly series of didactic slash, that's my daughter, didactic slash case-based learning. They occur at lunchtime. There's a Echo 101, which is kind of a large overview and tools of common conditions. And then there's a deep dive, birth through 5, that they did last year, and I have an opportunity to take this year. And that's about more mental health programs and needs in young children. Finally, what I'm involved with is the REACH education program. This is a course that costs $2,600 nationally and has a several-year waiting list if you sign up for it nationally. VMAP is giving it to us all for $100. It is a 16.5-hour, 3-day weekend. They call it a mini fellowship, but then it's followed by 12 case-based learning calls. That's kind of like the next level of complexity. And participants bring real cases, real kids to the table, and we discuss them. So we have 6 dates planned this year. These are the 5 that are up on the website. 2 are in person in Richmond. I can't wait, and we're crossing our fingers that they're going to work, and that we won't have to convert them to virtual. And there'll be a 6th in November. So if you haven't taken it, please sign up. What are people saying about our programs? Well, you can ask some current participants or recent participants. Ryan Fulton, I think, has done the program now. Laura Biscotti is involved. Hannah Smith is probably completed. Kiana Charles is doing it. Brenna Keene has done it, and Vidya Parmeshwar is in it right now. If I missed your name and you've done it, I'm sorry. These are the ones that I have on the top of my head. People nationally are paying huge money for REACH. Children's systems are sending all of their primary care through it. Ones who I know of recently are Texas Children's. I recently participated with Rady Children's out of San Diego. And there's a large donor in Atlanta. I would love to know who it is. I wonder if it's Oprah. And they are paying for anybody in multiple zip codes around the Atlanta area who does primary care to take REACH at full cost, $2,600 a participant. Inova in Virginia and CHKD have sent almost everyone through this program, and they even send residents. And we are exploring the idea of resident-only weekends, Kelly Henschel, for this REACH program. It would tick some of the boxes for the ACGME for you. So I promised you we're going to celebrate some of our successes at Carilion Children's. What have we done? We've got some screening out there. We've got the SEEK program that I talked about. We screen for postpartum depression in our primary care offices from birth to 6 months. We have developmental screening, which is important because we know our kids with alterations from the norm and development do have an increased risk of mental health disorders as well, including autism. So we have that developmental screening from birth to 5. We use PHQs to screen for depression from 12 and above. In the treatment side, I give Amy Kegels and her team huge props for this. They are working hard and continue to work hard. So we actually have emerging co-location of psychiatrists in our primary care offices. We've had Felicity Adams has been working with Jefferson, now Tanglewood, for a long time, but we haven't had any in our other offices. So Kate Lebesny is now working with Postal, and John Vance is now working with Botetourt. And it is resulting in my patients getting in to see them more quickly, and I'm so grateful for that. But they're actually going to start seeing patients physically in our offices fairly soon. We have pediatric psychologists, but not enough. So wait list is forever to use them for counseling. We have PCIT training, which is its whole thing in and of itself, but that is evidence-based, high quality behavioral health intervention for children with significant behavior problems. And last, we've got our outpatient social work, who are so valuable. So I called this, before I go on, I would challenge you to think about, what are we missing here? What can we do better? What do we need? Do we need education? Do we need processes? What is it we need? And by the way, folks, I've had people in Virginia who are hospitalists take the REACH program. I have an oncologist right now who's taking it because they take over primary care for their kids with cancer. We have NPs, we have PAs, we have family medicine docs, and we have pediatricians in that program. So in this periodic series, I can do some, but I can't do it all. And I'm not going to provide all of the detail that you need to do this work. But hopefully I can give you some information, some tools, and some reasons to treat. I'm going to talk about, I'm not going to give you problems without solutions. I'm going to talk about ADHD, depression, anxiety, suicide. And I want to do this over a period of time because VMAP is emerging. And I can also give you information about what is available or becoming available to us. For example, we are creating a guidebook which is a web-based tool available in other states, and we're creating our own for Virginia. This guidebook, I have the opportunity, I'm an author for it and an editor. So with that, I'm going to transition. And in the next probably 15 minutes, we're going to talk about a screening tool. I work with someone who says, before we can treat, we have to diagnose and assess. I work with someone that says we have to understand the messy soup in which these children live, because it's not just the drugs. Research has shown that in primary care, our largest barrier to treat is that we want diagnostic certainty. We're okay managing the drugs. We know how to give medications. But what we aren't okay with intellectually and on an emotional level is knowing that we're giving the drug for the right reason. So how do we do this assessment? We know that assessments develop our differential. They inform what is feasible in their treatment. And most importantly for mental health, we need to use it to develop a therapeutic alliance. Because if we don't have the family on board, we can't do anything for the child. So in the next 15 minutes, we're going to talk about what's the difference? What do we have available for us? What are rating scales? What are screening tools? What are advantages of various things? And I'm going to introduce and recommend a screener called the PSC. It is becoming the standard in Virginia for VMAP, in addition to the standard at the Reach Institute. Screening tools, they have to be cheap, they have to be quick, they have to be easy. They have to be sensitive, but they're not specific. They don't want to have false negatives. So some examples of screening tools that we already use are the ages and stages, in addition to the MCHAT. The PSC, or Pediatric Symptom Checklist, is another. What are rating scales? This is our Vanderbilt, our PHQ-9, the GAD-7, something that I like called the Columbia Depression, and the SCARED for anxiety. They're not diagnostic, but they're highly supportive of a diagnosis. They systematically ask questions about a condition, but the questions are tailored to that condition. So the PHQ-9 that we use is only really designed to screen for depression. What's the PSC? Well, there's a parent version that's validated down to age 4. Parent completes it, looking for symptoms that I'll show you in a minute. There's a youth version that is validated for 9 and above. I don't use it that young because I think the reading level is too high for many of our patients. You tend to use it more 11-ish, and it's youth completed. Like any screener, there's a total score, you screen in and out, but mostly it's looking at 3 domains: internalizing conditions, externalizing conditions, and problems with attention and focus. I had never heard of internalizing conditions or externalizing conditions. I got involved in this work with REACH and VMAP because I was hungry for the knowledge and knew I needed it, and said to Sandy Chung, how do we get this in Southwest Virginia? You've got it in Northern Virginia, at the beach, in Richmond, in Charlottesville. What about us down here? And then she wrote me in. So attention, that's easy. The features of ADHD, we kind of know them. Externalizing conditions are things that you see. These are acting out symptoms. So this is your kid who's defiant, aggressive, breaks rules, steals things. Internalizing conditions are things that the patient feels inside: depression, anxiety, loneliness, withdrawal, worthlessness. And parents and caregivers almost always underrate, not surprisingly, what the kid is feeling because they can only see it, they don't experience it. So we're going to see and score one, but it's easy. You just add numbers. And mostly I want to show you the tool itself, not get into the scoring, because that's something that's easy to learn. So if we look at the attention subscale, you can read it. It has a positive threshold and it's obviously the features of ADHD. Here is a PSC. Hopefully you've got a nice big screen and can see this, but it is, and I've got on this example PSC, we have the scores circled in green, just so you can see how it works. Patients or parents will say, this condition, this symptom never happens, it happens sometimes, or it happens often. You add up the ones and the twos and you drop them to the bottom. Here's the externalizing subscale. You can see why these kids are a challenge. They don't listen to rules, they tease, they don't share, they don't understand people's feelings. That's kind of interesting. They don't seem to have empathy sometimes. And here's what it would look like on a PSC. In this example, the kid has no externalizing symptoms. Our internalizing subscale primarily features of depression and anxiety, sadness, down on themselves, worries. But kids with ADHD often will score positive on this as well, because they know they're not doing well in school, they want to do well in school, and they're anxious about it. And they're getting a lot of negative messages if their behavior is a problem at home. So, okay, I've got a screener. Might be positive for some areas. What do I do about it? Well, we have a roadmap that we can give you. So this just shows numbers for positive screens. But if you screen positive for attention, well, maybe you've got an anxiety disorder that's keeping you from paying attention in school because you're worried about the lion in the corner of the room and you can't pay attention to the teacher. Maybe you've got ADHD. If you score high on externalizing, there's some conditions that go with that, including PTSD. If you score high on internalizing, you may have depression, you may have anxiety, and I will see some patients who score positive on those items as well with ADHD. And there are rating scales that I'm going to give you for each condition in our subsequent talks. So this is another place I may want you to put some things in the chat. Why are we thinking about why would I say we should use the PSC instead of the PHQ-9? What would be advantages of the PSC? Throw something in there. So hospital team says more thorough, screens for other diagnoses. Simple, broader differential, broader screening. It's non-specific, but points you where to go. Exactly, you guys are so smart. But mostly it's built for kids. It's one of my big reasons. The PHQ-9 is designed for adults and we extrapolated it down to adolescents. Added a few suicidality screening questions and called it the PHQ-9 for teens or youth, or I forget the exact other part, but it basically adds questions about suicidality. And for those of you who are interested in talking about it, I've got information about the sensitivity and specificity of these tools in addition to the GAD-7, which some folks use as well to screen for anxiety. But I don't want to bore you with that right now. So we're almost out of time, and I promised you 10-15 minutes to have a Q&A. So there's more to come. I hope I left you wanting more. And what is more to come is talking about the bread and butter of child mental health treatment. So if we can manage that, and our subspecialists can help us by supporting the kids when they see them, or referring to us when they have a hint of it, then child and adolescent psychiatry can take the rest. So I feel like I presented like some dismal things to you. And I wanted to just end with sharing a passage that I recently was given by a colleague named Paula Mannion from Northern Virginia. She's a nurse practitioner. So I told you I was going to make you feel a little uncomfortable. I want you to do something different. I'd like you to close your eyes, drop your arms down by your side, relax your shoulders, take a breath in and a breath out. and open your brains and your heart and your mind. Just listen. There's a Hopi elder prophecy that at least I found a publication date of 2000. I don't know how old this is. We are the ones we've been waiting for. You have been telling people that this is the 11th hour. Now you must go back and tell people that this is the hour. And there are things to be considered. Where are you living? What are you doing? What are your relationships? Are you in the right relation? Where is your water? Know your garden. It's time to speak your truth. Create your community. Be good to each other. And do not look outside yourself for your leader. Then he clasped his hands together, smiled, and said, "This could be a good time. There's a river flowing now very fast. It is so great and swift that there are those who will be afraid. They will try to hold on to the shore. They will feel that they are being torn apart and will suffer greatly. Know that the river has its destination. The elders say that we must let go of the shore, push off into the middle of the river, keep our eyes open and our head above the water. And I say, see who is there with you and celebrate. At this time in history, we are to take nothing personally, least of all ourselves. For the moment that we do, our spiritual growth and the journey come to a halt. The time of the lone wolf is over. Gather yourselves. Banish the word struggle from your attitude and your vocabulary. All that we know now must be done in a sacred manner and in celebration. We are the ones we've been waiting for. So I challenge you, open your eyes if you want to. We know there's a need. We have a community and a river with us. We've done some things already that have really been positive at Carilion Children's. There are resources available. We're not practicing in a vacuum. We're smart people. We can learn what we need to learn and at least do better tomorrow than we are today. Don't let perfection get in the way of better. Intervening for these children and these families doesn't just help the child in front of us. It helps the family and their mental health. It helps the other kids in school classrooms with them because they're not flipping desks and running away and taking up all the oxygen in the room for the teacher. And it can change the trajectory of that child's life. I am doing more good for them treating their ADHD and their aggression than I am ever treating their ear infection. So with that, folks, we have to do some MOC questions. So internalizing disorders. One, they're disorders where there is an internal derangement of thyroid function. Two, they're disorders with symptoms of withdrawal or sadness. Three, they're disorders with acting out or aggression. Two is the answer. Good job, folks. Second, there are adequate resources in Virginia to meet children's mental health needs. Yes or no? No, good. The arms of VMAP are education, care coordination, consultation, teleconsult services for the consults, more child and adolescent psychiatrists. Hannah, you got it. 1 through 4. Linda Keel, excellent. Hospitalist team, way to go.